Imagine sitting in a doctor's office, desperate for answers about this chronic, incredibly painful condition that's just destroying your digestive system.
Right.
And the doctor looks at your chart, leans back, and tells you that the best thing you could have possibly done to prevent your body from attacking itself was to have your appendix removed 20 years ago.
Which is wild.
Or, even more bizarrely, they look at your history and realize that the exact moment your disease triggered was the month you finally managed to quit smoking cigarettes.
It completely breaks the brain. I mean, it defies everything we think we know about healthy behaviors and biology.
Yeah, totally.
We are trained to think of medicine as this clean, logical progression, you know? You do bad things, you get sick. You do healthy things, you stay well.
But today, we are throwing that clean logic completely out the window. We are taking a deep dive into a clinical review from the NCBI bookshelf, unpacking a condition responsible for 250,000 medical visits in the U.S. alone every single year.
A massive number.
Right. A disease that costs the healthcare system billions and alters the lives of the people who have it in ways that are just hard to comprehend unless you've been there. We are unpacking ulcerative colitis, or, as we'll call it today, UC.
And if you're listening to this, whether you are a medical student trying to memorize the pathology, or, you have a personal connection to this illness, or you're just intensely curious about the human body, you are going to discover that UC is a masterclass in biological paradoxes.
It really is.
It is the absolute definition of diagnostic muddy waters. We are looking at a complex systemic rebellion where the body's own defense systems turn against the very tissues they're supposed to protect.
I really want to establish what this disease actually is fundamentally before we get into the wild triggers and the microscopic warfare, because I think a lot of people hear the word colitis and just think, oh, bad stomach ache.
Yeah, that happens a lot.
But this is an idiopathic inflammatory condition of the colon. Idiopathic, which is one of those great medical words that essentially means we have absolutely no idea what the singular root cause is.
It is a frustrating word for patients and doctors alike, frankly. Idiopathic means the disease arises spontaneously. Now, to be clear, we know the exact mechanisms of the damage.
Right.
We know precisely which immune cells are misbehaving, and we understand the inflammatory pathways involved. We just don't have that definitive patient zero trigger.
So we know the gun is loaded, and we know the bullet fires.
Exactly. But the finger pulling the trigger remains elusive.
Let's talk about the damage itself. The clinical definition involves diffuse friability, superficial erosions, and bleeding on the colonic wall. Friability is such a specific term.
It is.
If we were looking through an endoscope, what does a friable colon look like compared to a healthy one?
Well, to understand the disease, you have to picture the healthy state first. Imagine the lining of a healthy colon. It should look a lot like the inside of your cheek.
Okay, smooth and pink.
Yeah, smooth, pink, robust, and glistening. It's designed to handle the passage of solid waste, so it is highly resilient. But when tissue becomes friable, it loses all of that structural integrity.
It gets weak.
Incredibly fragile. It looks angry, red, and swollen. And the defining characteristic of friability is that the tissue bleeds at the absolute slightest provocation.
Oh, wow.
If a gastroenterologist just gently brushes the endoscope against it, or honestly, even if stool simply passes over it, the tissue begins to weep blood.
It's just totally raw.
Completely raw. And that leads to the superficial erosions, which are basically shallow ulcers where the top layer of cells has just completely sloughed off.
Which brings up a critical geographic distinction. The source notes that UC is restricted strictly to the mucosa and the submucosa. And that sounds like technical jargon, but it's the key to understanding how this differs from other diseases, right?
It is the defining anatomical feature, yeah. The wall of your colon isn't just one thick piece of meat. It's a layered structure, almost like the layers of a winter coat.
Okay, let's unpack this coat analogy. What are we looking at?
The innermost layer, the part that actually makes contact with the food, the bacteria, and the waste, is the mucosa. That's the lining. Just beneath that is the submucosa, which is this supportive layer filled with blood vessels and nerves. If you go deeper, you hit the muscularis propria.
That's the muscle that actually moves things along.
Exactly. It's the thick, heavy muscle layer responsible for contracting and moving waste through your system. And finally, the serosa, which is the smooth outer wrapping of the whole organ.
So UC is essentially an attack that only destroys the inner wallpaper of the house. It doesn't rot the wooden studs or the foundation.
Precisely. It is a superficial inflammation. It does not typically dig down into that thick muscle layer.
Like Crohn's disease does.
Right. It certainly doesn't punch all the way through the colon wall, which is something you might see in a transmural disease like Crohn's.
Got it.
Now, hearing that it is only superficial might sound reassuring, but you have to understand that the mucosal layer is the absolute front line of your immune system.
Because it touches all the bacteria.
Yes, it's where your body interacts with trillions of gut bugs. When that layer is systematically destroyed, the physical and systemic consequences are just devastating.
There's another major hallmark of UC that helps differentiate it from things like Crohn's, and that's the way it spreads. It typically starts in the rectum and extends proximally in a continuous manner.
Proximally meaning it moves backward up the digestive tract.
Okay.
The rectum is the very end of the line, so the inflammation ignites there, and then it marches upward into the sigmoid colon, then up the descending colon, across the transverse colon, and so on.
I visualize this like a house fire. The rectum is the basement. The fire always starts in the basement.
That's a great way to look at it.
And from there, it burns its way up the stairs, step by agonizing step. It burns the first floor, then the second floor, then the attic. But what it never does is skip a floor.
Never.
It never burns the basement, leaves the first floor completely untouched, and then starts burning the second floor. It's a continuous, unbroken path of destruction.
That is a brilliant way to conceptualize it. And it highlights exactly what gastroenterologists are looking for during a colonoscopy.
What do they see?
Well, if a doctor scopes a patient and sees a heavily ulcerated rectum, then a completely healthy, perfectly normal stretch of colon, and then another patch of severe ulcers higher up, they instantly know they are not looking at ulcerative colitis.
Because it skipped.
Exactly. Those are called skip lesions, and they are the classic signature of Crohn's disease. UC simply does not skip. The fire burns every single millimeter of the path it touches.
So we know what the fire looks like and how it moves. But who is most likely to experience this? If we look at the epidemiology, there are some really striking trends.
Very striking.
Worldwide, the highest incidence and prevalence are seen in Northern Europe and North America. And the research closely links this to a westernized environment and lifestyle.
Yes.
What is it about living in the West that sets the stage for our colons to just self-destruct?
It's one of the great modern medical mysteries, honestly, but we have some very strong theories. A westernized lifestyle carries a lot of baggage.
Like our diets.
Oh, absolutely. We have diets that are notoriously high in processed foods, saturated fats and refined sugars, and tragically low in complex, diverse plant fibers.
Right.
We also have high exposure to industrial pollutants and specific medications like antibiotics early in life.
And there's also the hygiene hypothesis, right? I've heard this brought up a lot with autoimmune stuff.
Yes, the hygiene hypothesis is a major player here. The premise is that in westernized societies, our environments are almost too clean.
Too clean.
Yeah. Our water is heavily purified, our food is sanitized, and our exposure to benign parasites and diverse soil microbes during infancy and early childhood is drastically reduced compared to developing nations.
Which sounds like a good thing on the surface, you know. We aren't getting cholera.
We aren't getting cholera, but we are paying a different price.
How so?
Well, the human immune system evolved over millions of years to constantly fight off a heavy load of parasites and microbes. It expects to be challenged.
You want to fight.
Exactly. When a child grows up in a hyper-sanitized environment, their immune system doesn't get properly trained. It's like a heavily armed military with no enemy to fight.
Oh, I see.
Without the normal pathogens to practice on, the immune system gets bored, it gets overly sensitive, and eventually it starts mistaking the body's own normal, healthy gut bacteria for deadly invaders. It turns its weapons inward.
That is wild. Being too clean fundamentally breaks our internal defense programming.
It really does.
And looking at the numbers, this isn't a rare anomaly. The incidence is around 9 to 20 new cases per 100,000 people every year.
Right.
And the prevalence, meaning the total number of people walking around with this right now, is up to nearly 300 cases per 100,000.
And it has a very specific bimodal pattern of onset. It doesn't strike evenly across the lifespan.
Right, there are two distinct peaks. The massive first peak hits people between the ages of 15 and 30.
Yes.
And then there's a smaller secondary peak later in life, between 50 and 70.
Let's really think about what that first peak means for a patient. Hitting between 15 and 30 is psychologically devastating. This is the prime of youth.
It's high school and college.
Exactly. These are kids finishing high school, moving into dorms, trying to start careers, trying to date and form romantic relationships.
Yeah.
And right at the moment they're supposed to be stepping into their independence, they are struck by a chronic, lifelong, and incredibly embarrassing illness that tethers them to the proximity of a bathroom.
The psychological trauma of navigating a newly bleeding colon while trying to navigate your freshman year of college just cannot be overstated.
It's completely life-altering.
Okay, so we know where the fire starts, and we know who it tends to hit. But what is striking the match? Let's dive into the roots of the disease, the genetics, the environmental triggers, and the paradoxes I mentioned at the top of the deep dive.
The causes and risk factors. This is where the biological detective work gets really complex.
The clinical research clearly points to a massive genetic component. Family history is universally cited as the most important independent risk factor.
It is.
It accounts for about 8 to 14% of all patients. If you have a first-degree relative, so a parent, a sibling, or a child who has UC, your personal risk of developing it is 4 times higher than the general population.
And it also shows a consistently higher incidence in Jewish populations compared to other ethnicities.
Which confirms without a doubt that genetics build the foundation of this disease.
They absolutely do. There are specific genetic susceptibilities, most of which dictate how the mucosal immune system recognizes and tolerates bacteria in the gut.
Okay.
But here's the critical caveat. Genetics alone are not enough. We know this from studying identical twins.
Oh, really? What happens with twins?
If one identical twin has ulcerative colitis, the other twin does not automatically get it 100% of the time. They share the exact same DNA, but they don't share the exact same disease fate.
So if the genetics load the gun, something in the environment still has to reach out and pull the trigger.
Exactly. The DNA creates a vulnerable environment, but an external catalyst is required to initiate the autoimmune cascade.
And the research points to several potential catalysts: altered gut microbiota, defects in mucosal immunity, and general autoimmunity. But this brings us to the first massive head-scratching paradox.
Yes.
The smoking paradox. I
Yeah.
read this over and over to make sure I wasn't misunderstanding it.
It is arguably one of the most consistently observed, yet completely baffling phenomena in all of gastroenterology.
The data shows an increased prevalence of ulcerative colitis in non-smokers, or specifically in people who've recently quit smoking.
Right.
And furthermore, if you do have UC and you actively smoke cigarettes, you tend to have a milder course of the disease, fewer hospitalizations, and a reduced need for heavy medications.
It's true.
I have to push back here. How on earth does actively inhaling toxic carcinogenic smoke, which destroys your lungs, ruins your heart, and causes cancer, somehow act as a protective shield for your colon?
It is the ultimate contradiction. And let's establish a massive disclaimer immediately. No ethical doctor on the planet is going to prescribe a pack of cigarettes to treat ulcerative colitis.
Right, obviously.
The systemic risks of smoking lung cancer, emphysema, heart disease, stroke far, far outweigh any localized benefit to the colonic mucosa.
But purely from an immunological and scientific standpoint, it provides an incredible clue about how the disease works. Do we know how it works? What is the smoke actually doing to the gut?
The exact mechanism is still intensely debated, but the primary suspect is nicotine.
Nicotine, yeah.
Nicotine has highly complex effects on the immune system. It appears to suppress certain specific inflammatory pathways that are overactive in UC.
Interesting.
Additionally, nicotine and other compounds in the smoke might physically alter the mucus production in the colon, forcing the goblet cells to produce a thicker, more resilient protective moat.
So it thickens the wall.
Right. There's also evidence that smoking alters the microvascular blood flow to the colonic lining in a way that somehow dampens the inflammatory response.
It's like the immune system is a hyperactive, confused guard dog that is just destroying the living room furniture.
That's one way to put it.
And the only way to get it to stop chewing the sofa is to constantly blow smoke in its face to distract it.
Exactly.
It's a terrible, toxic long-term strategy for the dog's health, but in the short term, the sofa survives.
That's a chaotic but highly accurate analogy. And the flip side of this paradox is what breaks doctors' hearts.
Because they quit.
Yes. You have these patients who finally do the right thing. After years of struggling, they quit smoking to save their lungs and their heart.
And then what?
And within months, sometimes weeks, they develop their very first catastrophic flare of ulcerative colitis. The artificial protective suppression of the smoke is lifted, and their underlying genetic predisposition just explodes.
That feels like a cruel joke.
Oh?
You take control of your health, you quit smoking, and your colon instantly declares war on you as a reward.
It is a profound irony, and it's a known clinical phenomenon. When a patient with a family history of inflammatory bowel disease decides to quit smoking, their gastroenterologist has to be on high alert.
Wow. The research also highlights a link with NSAID's non-steroidal anti-inflammatory drugs.
Yes.
So we're talking about common over-the-counter stuff like ibuprofen, naproxen, Advil, Alev. It notes that there's an association between using NSAIDs and either the initial onset or a sudden relapse of UC.
Right. And while the evidence for NSAIDs actually causing the initial onset is considered a bit weak on a population level, gastroenterologists universally advise their UC patients to treat NSAIDs like poison.
But wait, why? I thought they were anti-inflammatory. Shouldn't they reduce inflammation in the gut?
It's about exactly how they reduce inflammation. NSAIDs work by blocking specific enzymes in your body called COX-1 and COX-2.
Okay.
When you block these enzymes, you stop the production of prostaglandins, which effectively reduces pain and inflammation in your head if you have a headache, or your knee if you have arthritis.
That sounds like a good thing.
But here's the catch. Those exact same prostaglandins are responsible for stimulating the production of the protective mucus lining in your stomach and your intestines.
Oh, so by fixing your headache, you are shutting down the mucin factory in your gut.
Exactly. You are thinning out the protective barrier of the colon.
Yikes.
For a normal person, taking an Advil might cause a little stomach upset, but for a patient with ulcerative colitis, thinning that barrier is like opening the gates of the fortress.
Just lets everything in.
It allows bacteria to penetrate the lining, which wakes up the dormant immune system and triggers a massive relapse.
Okay, if the smoking paradox was wild, this next one is the true mind bender of the disease, the appendix mystery.
Oh, this is fascinating.
The clinical data states, quote, appendectomy before the age of 20 is associated with a decreased incidence of ulcerative colitis.
Yes.
In fact, it says appendectomy has been shown to reduce the risk of developing ulcerative colitis by 69%, a 69% reduction.
It is a staggering, almost unbelievable statistic in the world of autoimmune disease.
I mean, that's huge.
And what makes it even more fascinating is the contrast. If you look at Crohn's disease, which is UC's sister illness, removing the appendix actually does nothing to protect you.
Really?
Yeah, and in some studies, it might even worsen the onset of Crohn's. But for UC, it is massively, undeniably protective.
But biologically, how is that possible? When I was in school, I was taught the appendix was a completely useless vestigial organ.
We all were.
It was just a tiny explosive time bomb attached to the large intestine that did nothing but occasionally rupture and try to kill you. Why would surgically removing a useless organ at age 15 halt a massive autoimmune cascade across the entire colon when you are 40?
This completely upends the archaic idea that the appendix is useless. Current immunological research has completely rebranded the appendix.
Rebranded it how?
We now understand that it is densely packed with specialized lymphoid tissue. It is essentially a safe house or a highly specialized training ground for gut bacteria and immune cells.
Like a military boot camp for the immune system.
It's exactly like a boot camp. Because the appendix is this little blind-ended pouch tucked away near the start of the large intestine, it acts as a reservoir.
Okay.
It's where the naive immune cells first truly interact with the complex microbiome of the gut. They go there to learn who the good guys are and who the bad guys are.
That makes sense.
The working theory right now is that in people who are genetically predisposed to ulcerative colitis, the appendix is the primary site where the immune system is radically miseducated.
Wait, so the appendix is where the immune cells are taught to attack the body?
That's the theory. It's where the immune cells first learn to inappropriately identify normal, friendly gut bacteria as hostile invaders.
Oh, wow.
If you remove the appendix at a young age, specifically before age 20, before the immune system has fully matured and deployed its forces, you are essentially tearing down that rogue boot camp.
You're blowing up the training facility.
Yes. You are destroying the training facility before the poorly trained radicalized immune cells can graduate, multiply, and deploy throughout the rest of the colonic tissue.
That is just, it's phenomenal. By taking out this tiny pinky-sized pouch, you prevent the radicalization of the entire immune network.
It shows how incredibly interconnected every single millimeter of the gut really is.
It really does. A localized anatomical change at the very beginning of the large intestine dictates the immune fate of the entire organ decades later.
Absolutely.
So we've talked about the bizarre setups, the genetics, the twin studies, the environmental triggers, the paradoxes of smoke and surgery.
Right.
But what happens when the disease is actually triggered? When the match is finally struck, what does the resulting cellular warfare actually look like?
Let's zoom way in on the pathology and the pathophysiology.
This is where we shift from the macroscopic view of the patient's lifestyle down to the microscopic molecular reality of the colon wall.
Okay, let's get into the microscopic war.
What we see is a multi-front war. It involves a catastrophic breakdown of the physical barrier, an aberrant and hysterical immune response, and a massive coordinated recruitment of biological artillery.
So let's start with the physical wall itself, the epithelial barrier. Right.
The research notes a profound defect in colonic mucin and a failure of the tight junctions, leading to an increased uptake of luminal antigens. Let's translate that.
Think of the epithelial layer as the stone fortress wall of your colon. Its primary job is to keep the trillions of bacteria, fungi, and viruses living in your gut, the microbiome, from getting inside your actual bloodstream and internal tissues.
Right, because if you think about it, the tube of the digestive tract is essentially just a tunnel going through us.
Exactly.
The food and bacteria inside the colon are technically still outside the body's internal sterile environment.
That's exactly right. The lumen, the hollow space inside the colon, is outside the body. To protect the wall from this massive bacterial load, your specialized goblet cells secrete mucin.
And mucin is what exactly?
Mucin is a thick, highly viscous, sticky mucus that coats the wall. It acts exactly like a moat around the fortress.
Okay, I can picture that.
And the cells of the wall themselves are physically bound together by proteins called tight junctions. Imagine heavy iron gates locking the stone blocks of the wall together so nothing can squeeze between them.
So what goes wrong in UCI?
In ulcerative colitis, the fortress fails entirely. The goblet cells get sick and the mucin production drops. The moat dries up.
Oh, no.
And those heavy iron gates, the tight junctions, begin to rust and fail. They literally open up, creating microscopic gaps between the cells.
Which is the literal definition of leaky gut, right?
Yeah.
A term you hear thrown around a lot in pop wellness. But here, it's an actual severe pathological state.
Yes, increased intestinal permeability. And when those gates open, luminal antigens, which are bits of bacteria, undigested food particles, and bacterial toxins, leak right through the broken fortress wall.
And they drop down into the underlying tissue.
Exactly, down into the lamina propria.
And that tissue isn't empty. That's where the immune system's guards are waiting.
Right.
The clinical data talks about an increased number of activated and mature dendritic cells in this area. What is a dendritic cell?
Dendritic cells are the specialized intelligence officers of the immune system. They constantly patrol the tissues just under the surface.
Okay, so they're on guard duty.
Yeah. When they encounter a foreign antigen that leaked through the broken wall, they physically capture it, process it, and then travel to the local lymph nodes to present this captured enemy to the heavy artillery of the immune system.
Effectively initiating a massive immune attack.
Exactly.
And to figure out what they're looking at, they use something called toll-like receptors. The research specifically highlights an abundance of TLR2 and TLR4 in UC patients.
Toll-like receptors, or TLRs, are the biological radar system of the immune cells.
Radar system, got it.
They are specialized proteins that stick out of the dendritic cells, and they are evolutionarily engineered to be incredibly good at recognizing common molecular patterns found on the surface of bacteria and viruses.
So they scan for threats.
Right. In a perfectly healthy gut, this radar system is finely tuned. It knows how to stay calm and ignore the friendly commensal bacteria that help us digest our food. It only sounds the alarm for true pathogens like salmonella.
But in UC, that radar is broken.
It is severely broken. There is a massive overexpression of these TLR2 and TLR4 radars on the dendritic cells.
So there are too many radars.
Yes. And the intelligence officers become hypervigilant. Their radar is so sensitive that they begin misidentifying completely harmless, normal gut bacteria as deadly invaders.
That's a disaster.
It is. And once they capture these normal bacteria and sound the alarm, they trigger an atypical and highly destructive immune response.
The science identifies this specific response as an atypical T helper cell response,
Right.
specifically a Th2 response. And it says it exerts a cytotoxic effect against the epithelial cells. Break down the chain of command here.
T helper cells are the generals of the immune system. They don't do the killing themselves. They decide what kind of army to deploy.
Okay, so the generals get the call.
Usually, a Th2 response is geared toward fighting off parasitic worms or dealing with allergic reactions. But in UC, this Th2 response is inappropriately activated by the panicked intelligence officers.
And worse, it becomes cytotoxic.
Yes, which literally means cell killing.
So it's friendly fire.
It is the ultimate friendly fire. The generals order the immune system to actively bomb its own fortress wall.
Wow.
The immune cells release chemicals that destroy the very epithelial cells that are trying to rebuild the wall and keep the bacteria out.
That makes no sense from a survival standpoint.
It doesn't. It becomes a runaway vicious cycle. The wall breaks down, more bacteria leak in, the radar screams even louder, the generals order more artillery, and the immune system bombs the wall even harder.
And the chemical mediators of this bombing campaign are intense. The literature lists tumor necrosis factor alpha, or TNF-alpha, interleukin-13, and natural killer T cells.
Yes.
Plus, a disproportionate increase in IgG1 antibodies.
Yeah.
Let's focus on TNF-alpha because that seems to be the main villain.
TNF-alpha is a massive systemic driver of inflammation. It is a cytokine, which is a signaling protein.
What?
Think of it as the immune system's master switch for chaos. When TNF-alpha is released into the tissue, it causes blood vessels to dilate, it causes swelling, it causes pain, and it summons even more immune cells to the area.
So it just amplifies everything.
Exactly. If you can somehow reach in and turn off that TNF-alpha switch, which, as we'll see later, is exactly what the most advanced biologic medications are designed to do, you can often shut down the entire war.
I want to talk about how the body actually gets more troops to the battlefield, because the mechanics of this are mind-blowing.
It's a fascinating process.
The research describes something called leukocyte recruitment. It says there's an upregulated release of the chemoattractant CXCL8
Right.
and an upregulation of something called mucosal cellular adhesion molecule 1, or MADTM1.
This is one of the most beautifully orchestrated, albeit completely destructive biological processes in the human body.
Let me try out an analogy here, because picturing this helped me understand the sheer scale of the inflammation. The battle is raging in the tissue of the colon. The local guards are getting overwhelmed.
Okay, set the scene.
So they release this chemical, CXCL8. To me, CXCL8 is a literal flare gun. They shoot this chemical flare up out of the tissue and into the local bloodstream to call for backup.
That is exactly what a chemoattractant is. It creates a chemical gradient, a scent trail, essentially for white blood cells, or leukocytes, circulating in the blood to follow. They smell the CXCL8 and know there is a war nearby.
But the blood in your veins is moving fast. The white blood cells are zooming by like cars going 80 miles an hour on a highway.
Right, they're moving very quickly.
How do they know exactly where to pull over and jump out of the bloodstream to get to the colon? That's where MADCM1 comes in.
Exactly.
The text says it's expressed on the endothelium of mucosal blood vessels and promotes leukocyte adhesion and extravasation. So MADCAN1 is like the local colon cells rolling out strips of Velcro or police spike strips right on the inner walls of the blood vessels, exactly where the battle is happening.
This spike strip analogy is perfect. The white blood cells catch the scent of the CXCL8 flare. They physically alter their shape and slow down.
They hit the brakes.
Yeah, and then they hit the MADCAM1 Velcro on the blood vessel wall. They physically stick to it, stop rolling in the bloodstream, and then they squeeze themselves between the cells of the blood vessel wall.
That's extravasation.
Exactly. They dive directly into the colonic mucosal tissue to join the friendly fire.
The sheer physics of a cell stopping in a rushing river of blood and squeezing through a wall to go fight a war is incredible.
It's biologically stunning.
But the result of all this microscopic warfare is devastating. When pathologist takes a biopsy of this tissue and looks at it under a microscope, what do they see?
They see the aftermath of the battle.
The histopathology sections mention dense infiltrates of lymphocytes, plasma cells, and granulocytes.
Which is just the physical cellular evidence of the armies that arrive via that Velcro system. Granulocytes, specifically neutrophils, are the heavy infantry of the immune system.
Okay, the heavy infantry.
When a pathologist sees the tissue just swarming with neutrophils, it is the hallmark of an acute, highly active, raging flare of the disease.
It also mentions goblet cell depletion and crypt alterations.
Remember those goblet cells? The ones responsible for producing the mucin moat.
Right, the ones making the mucus.
Because the tissue is under such heavy, sustained fire, these cells simply die off or become exhausted and depleted. The moat completely disappears.
And the crypts.
The crypts, which are the deep, microscopic glandular valleys in the colon lining, become distorted, branched, and structurally warped by the endless, frantic cycles of damage and incomplete repair.
So the whole structure is ruined.
The architecture of the tissue is fundamentally ruined, yes.
And there's this really weird phenomenon mentioned at the end of the pathology data, backwashulitis.
Oh.
It says these severe inflammatory findings might also be present in the distal ileum, even though UC is, by definition, strictly confined to the colon. How does that happen?
It's collateral damage, pure and simple. The distal ileum is the very last few inches of the small intestine, right before it connects to the large intestine at the cecum.
Okay, so right next door.
Now, the immune system in UC is programmed to only attack the colon. But the sheer volume of inflammatory chemicals, toxic cytokines, and hostile immune cells sloshing around in the right side of the colon is so massive that it can literally backwash.
It just spills over.
Yeah, it backwashes through the ileocecal valve and spills backward into the small intestine. It causes a reactive, chemical burn of inflammation in an area the disease isn't even targeting.
That's terrifying. So we have a hyperactive radar, broken stone walls, chemical flare guns, and Velcro spike strips pulling in a massive army of white blood cells that are engaged in relentless friendly fire.
That sums it up.
This microscopic chaos obviously reaches a tipping point where the patient doesn't just have weird cells, but actual debilitating symptoms.
And unfortunately, the transition from microscopic damage to macroscopic suffering is brutal.
This brings us to the physical toll. How does this cellular war manifest in the patient's daily life, both inside the colon and, which surprised me the most, outside of it?
The internal and external impact.
The primary symptoms listed are intense, bloody diarrhea, with or without mucus, severe urgency, tenesmus, abdominal pain, malaise, profound weight loss, and fever.
The defining, inescapable symptom of ulcerative colitis is bloody diarrhea. Because that superficial mucosal layer is completely ulcerated, stripped away, and highly friable, it constantly weeps blood, pus, and inflammatory fluid directly into the bowel.
Just constantly bleeding.
Furthermore, a healthy colon's main job is to absorb water from liquid waste to form solid stool.
Right.
When the lining is a raw, inflamed wound, it completely loses its ability to absorb that water. The result is frequent, entirely liquid, bloody bowel movements.
And tenesmus. I want to focus on this word because the clinical definition doesn't fully capture the agony of it. What is tenesmus physically?
Tenesmus is arguably one of the most psychologically and physically distressing symptoms in all of gastroenterology.
Why is that?
It is the intense, continuous, cramping, and highly uncomfortable feeling that you need to pass stool immediately, even when your bowels are completely 100% empty.
I've heard it described almost like a phantom limb sensation, but for your rectum?
That is exactly what it is. The rectum is the final holding chamber. Normally, when it fills with stool, it stretches, and those stretch receptors send a signal to your brain saying, time to find a bathroom.
Okay, that's normal.
But in UC, the rectum is so massively swollen, engorged with blood, and inflamed that the nerve endings are constantly stretched just by the inflammation itself.
So the brain is tricked.
Yes, the brain interprets this severe swelling as the rectum being dangerously full. So the patient feels this agonizing, urgent need to rush to the bathroom.
But there's nothing there.
Right. When they get there, they strain and nothing happens, or they just pass a tiny amount of blood and mucus.
And this isn't just once a day. This could be 20, 30 times a day.
Yes. It severely limits a person's basic ability to function. You can't leave the house, you can't commute to work, you can't sit through a movie, you can't sleep through the night.
It dictates everything.
The proximity of a toilet dictates every single decision in your life.
And the disease course is characterized by spontaneous remissions and relapses. So a patient might suffer like this for months, then suddenly the immune system backs off, the wall heals a bit, and they feel okay for a year.
Right.
And then bam, the fire flares up again. But here's the part that I think most people, even some patients who have the disease, don't fully grasp.
Which part?
The disease doesn't just stay in the gut. The clinical review details a whole host of extraintestinal manifestations, or EIMs. These occur in 10 to 30% of all patients.
This is a vital concept for the public and the medical community to understand.
Why does it leave the gut?
We classify ulcerative colitis as an inflammatory bowel disease, but fundamentally, it is a systemic immune disorder.
Okay.
When the immune system is that highly activated, when those generals are constantly screaming for war and pumping TNF-alpha into the blood, it doesn't always neatly contain its aggression to just the colon.
It travels.
The inflammatory markers circulate throughout the entire vascular system.
The research categorizes these EIMs into two distinct buckets. Activity-dependent, meaning these symptoms flare up exactly when the colon flares up, and activity-independent, meaning they run on their own completely separate schedule.
Right.
Let's look at the activity-dependent ones first. It lists episcleritis, scleritis, and uveitis. Those are inflammatory conditions of the eye. How does a colon disease make you go blind?
It comes down to cellular similarities and circulating immune complexes. The eyes are highly vascularized organs.
Lots of blood vessels.
Yes. And they contain tissues that, on a deep molecular level, share some structural similarities or specific protein antigens with the tissues of the gut.
Oh, I see.
Or the immune complexes that are formed in the gut simply travel through the blood and get physically lodged in the tiny capillaries of the eye.
So the body thinks the eye is the gut.
In a way, yes. A patient might start having severe bloody diarrhea, and 2 days later they develop intensely red, burning, painful, light-sensitive eyes.
Wow. It also mentions peripheral arthropathy, so severe joint pain in the knees, elbows, and wrists.
Yes.
And then skin conditions, specifically erythema nodosum and pyoderma gangrenosum.
These skin conditions are horrific. Erythema nodosum presents as painful, raised, hot red nodules, typically erupting all over the shins.
Right.
And pyoderma gangrenosum is even more severe and terrifying. It often starts looking like a simple bug bite or small blister, but it rapidly degrades and necroses into a massive, deep, incredibly painful, open ulcer on the skin.
And that's not from an infection.
No, this is not an external infection. This is the body's own immune neutrophils, the heavy infantry inappropriately attacking the skin tissue, driven by the exact same systemic dysregulation that is currently attacking the colon.
So if you're a patient, what does this actually look like in practice? You go to your general practitioner because your eyes are bright red and burning, you have these massive painful bumps on your shins, and your knees are swelling up.
Right, a confusing mix of symptoms.
And the doctor looks at you and says, actually, this is a colon problem. How often is this misdiagnosed before a doctor finally connects the dots?
Tragically, it is misdiagnosed all the time. If a patient hasn't yet developed the classic bloody diarrhea, or if they are young and downplaying their gastrointestinal symptoms out of sheer embarrassment, a GP might just treat the eye inflammation with eye drops.
Or send them to a dermatologist for the skin.
Exactly, or a rheumatologist for the joint pain.
Yeah.
They treat the manifestations in isolation. It requires a really astute clinician with a holistic view to step back and realize, with the eyes, the skin, the peripheral joints, we need to scope the gut.
And what about the activity-independent EIMs, the ones that just do whatever they want?
Those are insidious.
The literature mentions axial arthropathies, sacroiliitis, and ankylosing spondylitis.
These affect the central skeleton, the spine, and the pelvis. Ankylosing spondylitis is a particularly severe chronic inflammation of the spine.
What does that do over time?
If left untreated, it can eventually lead to the individual vertebrae physically fusing together, creating a rigid, inflexible spine.
Like a bamboo spine.
Exactly. The critical, terrifying thing here is the activity-independent label. This means that a patient could have their UC completely under control.
Even if the colon is fine.
Yes. Their colon could be perfectly healed, or they could have even had their entire colon surgically removed. And yet, the spinal inflammation might continue to relentlessly progress on its own.
That is so unfair.
It has a separate, parallel immunologic pathway, strongly associated with a specific genetic marker called HLA-B27.
And finally, under these extraintestinal manifestations, there is a highly significant hepatic or liver complication. Primary sclerosing cholangitis, or PSC.
PSC is a chronic progressive inflammation and subsequent scarring of the bile ducts, both inside and outside the liver.
So the bile gets trapped.
Yes. Over time, as the scarring thickens, it narrows the ducts, causing toxic bile to back up into the liver tissue itself, which can eventually lead to outright liver failure.
And the clinical data says that having PSC concurrently with UC significantly massively increases your risk of developing colorectal cancer.
It's a severe complication that requires intense, specialized monitoring by a hepatologist.
Which brings us perfectly to the detective work. If the symptoms can be this incredibly broad, spanning from bloody diarrhea to red eyes to spinal fusion to liver failure, how do doctors definitively prove that the culprit is ulcerative colitis?
It's a complex process.
We're moving into the evaluation, staging, and tracking of the disease.
The diagnosis of UC is never made with a single, simple blood test. It requires assembling a complex mosaic of clinical findings, direct endoscopic visualization, microscopic tissue biopsies, and crucially, negative lab results for other simpler causes.
The research is emphatic that ruling out infectious causes is absolute step one. It explicitly states that colonic infection can produce clinical findings that are indistinguishable from idiopathic ulcerative colitis.
And this is a matter of life and death. Before you look a patient in the eye, condemn them to a lifelong diagnosis of an incurable autoimmune disease, and start pumping them full of heavy immunosuppressants, you absolutely must ensure they didn't just pick up a nasty bacterial infection from undercooked chicken.
Right, because if they have salmonella,
If a patient actually has Salmonella, Campylobacter, or a severe C. diff infection, their colon will be bleeding and inflamed.
and if you misdiagnose that,
If you misdiagnose that as UC and give them high-dose steroids, you will suppress their immune system, turning off their ability to fight the bacteria.
that sounds fatal.
It can be. The infection will run rampant, cross into the bloodstream, and it can easily be fatal. So exhaustive stool tests for bacterial, viral, and parasitic bugs are mandatory.
Once infections are completely ruled out, the doctors look at imaging and endoscopy. There's a fascinating radiological finding mentioned here for patients who have had UC for a long time. The stovepipe sign on a double contrast barium enema. What is a stovepipe colon?
Think about the normal structure of a colon. A healthy colon is not a smooth garden hose.
Okay, what does it look like?
It has deep, natural muscular folds and segmented pouches called haustra. It looks a bit like a concertina or an accordion. These holds help mix the stool and drastically increase the surface area so the colon can absorb more water.
That makes sense.
In chronic, long-standing ulcerative colitis, the constant, decades-long cycles of deep inflammation, ulceration, and thick fibrotic scarring completely obliterate these folds.
The folds just vanish.
The accordion is essentially glued shut and smoothed over. The colon becomes rigid, drastically shortened, and completely smooth on the inside.
Like a metal pipe.
On an X-ray, it looks exactly like a smooth, featureless, rigid metal stovepipe. It has lost all of its complex, functional architecture.
But the absolute gold standard for diagnosis is looking directly inside with a camera. Colonoscopy or proctosigmoidoscopy.
Right.
The text says the camera reveals a loss of typical vascular pattern, granularity, friability, and ulceration in that symmetric continuous pattern we established earlier.
Yes. When a gastroenterologist advances the endoscope into a healthy colon and shines the bright light on the mucosa, they should be able to see a fine, beautiful network of delicate blood vessels just under the surface, very much like looking at the blue veins on the back of your hand.
Okay, the normal vascular pattern.
That is the normal vascular pattern. In a patient with UC, the tissue is so profoundly swollen, inflamed, and engorged with edema and infiltrating immune cells that this delicate vascular pattern is completely obscured.
But it just disappeared.
The surface looks angry and granular, like wet, bloody sandpaper. And as they advance the scope, the friability and the deep, weeping ulcers are visually unmistakable.
And then we have the systemic lab markers, the blood tests. The literature mentions elevated ESR, CRP, and leukocytosis.
Those are general markers of inflammation anywhere in the body.
But then it gets highly specific with antibody testing. It notes that 60 to 70% of UC patients test positive for an antibody called PANCA.
Right. PANCA stands for perinuclear antineutrophil cytoplasmic antibodies.
That is a mouthful.
It is an autoantibody, meaning it's a specific antibody the body inappropriately manufactures to attack its own neutrophils, those heady infantry immune cells.
And the research contrasts this with ANCA anti-Saccharomyces cerevisiae antibodies, which are much more prevalent in Crohn's disease. I absolutely love this part because it is pure forensic detective work.
It really is.
Let me use an analogy here to see if I grasp how doctors use this. Comparing PANCA and ASCIA is exactly like finding a specific brand of footprint at a crime scene.
Okay, I like where this is going.
PANCA is like finding a distinct Nike footprint. It tells the detective the culprit is highly likely to be ulcerative colitis, whereas an ASCIA footprint, maybe an Adidas print, points the finger heavily at Crohn's disease.
That is precisely how it is utilized clinically. Neither test is 100% perfect, and you don't use them to make a diagnosis in isolation.
Right, they're clues.
But often, a doctor is looking at a patient with what we call indeterminate colitis. The visual evidence from the colonoscopy is a bit ambiguous, and the pathology report is borderline.
So they run the panel.
Running this antibody panel helps tilt the statistical probability toward one diagnosis over the other. If you have a patient who is strongly PANCA positive and totally ASCA negative, the diagnostic needle swings heavily toward UC.
But before a patient even gets to the terrifying, invasive prep of a full colonoscopy, there is a test that the clinical review highlights as an incredibly highly useful gatekeeper. Fecal calprotectin.
Yes.
It says it's non-specific, but it correlates directly with increased neutrophils in the intestine. Less than 1% of patients with low fecal calprotectin are likely to suffer from inflammatory bowel disease.
Fecal calprotectin has truly revolutionized the day-to-day practice of
Well,
gastroenterology.
what exactly is it measuring?
Calprotectin is a specific zinc-binding protein that is found abundantly packed inside neutrophils. When those heavy infantry neutrophils rush to the gut to fight this phantom war, they have a short lifespan.
They die off.
They eventually die, break open, and physically spill their internal calprotectin directly into the stool.
So the test is essentially measuring the body count of the white blood cells in your waste.
Exactly. It is a highly sensitive, direct measurement of intestinal inflammation. And the absolute beauty of it is that it's completely non-invasive.
You provide a sample.
It requires nothing more than a simple stool sample collected at home. If a young patient comes into the clinic complaining of diarrhea and abdominal cramping, their doctor can order a fecal calprotectin test.
And if it's low,
If that number comes back very low, the doctor can confidently say your symptoms might be irritable bowel syndrome or IBS or stress or a mild food intolerance, but there is absolutely no active inflammatory war happening in your gut.
so no need for a scope.
We do not need to put you through the stress and cost of a colonoscopy right now. It's an incredible triage tool.
Okay, so the detective has gathered all the evidence. The stool tests, the blood markers, the biopsies. The diagnosis is confirmed. The next step the doctor takes is staging the disease.
Right.
The standard mentioned is the Montreal classification system, which determines extent and severity.
Extent is purely about geography. How far up the colon has the basement fire spread?
Okay, what are the levels?
The Montreal system breaks it down. E1 is proctitis, meaning the fire is confined strictly to the rectum. E2 is left-sided or distal colitis, meaning the inflammation extends past the rectum, up the descending colon, stopping at the splenic flexure.
Not E3.
And E3 is pancolitis, meaning the entire large intestine from the rectum all the way to the cecum is engulfed in flames.
And then there's the severity scale, which ranges from S0, which is clinical remission, all the way up to S3, which is severe. And severe is clinically defined here as having more than 4 bloody stools a day, plus systemic features of illness, combined with hypoalbuminemia. Break down what that actually means for the patient lying in the hospital bed.
Systemic features mean the patient's body is showing signs of overwhelming toxicity.
Like what?
They have a high fever, a racing heart rate tachycardia as the body tries to compensate, and profound anemia from the constant daily blood loss into the toilet.
And the hypoalbuminemia.
That means the levels of albumin, a crucial protein in the blood, are plummeting. This happens because the patient is literally weeping protein out through the raw, inflamed gut lining, and they are likely too malnourished to produce more.
So they're in really bad shape.
A patient hitting the S3 criteria is not just uncomfortable, they are in a dangerous, highly unstable, potentially life-threatening state.
Which brings us to the counterattack. Once the diagnosis is locked in, the disease is staged, and the severity is known, how does medicine fight back?
We deploy the arsenal.
What is the arsenal? Let's look at the medications and the treatment ladder. The reassuring news in the data is that the overall prognosis during the first decade of the disease is generally good. And with modern medicine, most patients do achieve clinical remission.
Yes, that is the goal. The treatment approach is heavily dictated by those Montreal classifications, the extent and the severity.
It's a step-up approach, right?
In gastroenterology, we utilize a step-up approach. You start with the mildest, safest, and most targeted interventions first. You only step up the ladder to heavier, more systemic, and riskier artillery if the disease proves to be refractory.
Refractory meaning it resists the drugs.
Exactly.
The first line of defense listed on the bottom rung of the ladder is sulfasalazine and 5-aminosalicylates, or 5-ASAs. These can be administered orally or rectally.
Right.
And the data notes a remission rate of about 50%. It also specifically highlights that rectal applications like suppositories or medicated enemas help target the distal colon and significantly decrease that agonizing tenesmus we talked about earlier.
5-ASAs are a fascinating class of drugs. They are chemically related to aspirin, but they are brilliantly engineered so that they are not immediately absorbed into the bloodstream when they hit the stomach or the upper GI tract.
They survive the journey.
They survive the journey and travel intact all the way down to the colon, where they act purely topically.
That's clever.
They do not suppress the patient's entire immune system. They simply bathe the inflamed mucosal lining in a soothing, anti-inflammatory chemical coating.
So if a patient has E1 proctitis, meaning the fire is only in the basement, giving them an oral pill that has to travel through the entire digestive system might not be as efficient as simply giving them a suppository that applies the medicine directly to the burn itself.
Precisely. Topical therapy for distal disease is highly effective and avoids systemic side effects.
But they can mix them, right?
And as the research notes, even for more extensive disease, doctors will often combine oral pills with rectal therapies to hit the mucosal inflammation from both the top down and the bottom up simultaneously.
Let me use another analogy to contextualize these drugs, because the distinction between rescue meds and maintenance meds is huge.
It is the most important concept for patients to learn.
If steroids, which we'll get to in a second, are like a massive chemical fire extinguisher, great for putting out a sudden raging blaze, but terrible if you keep spraying them everywhere because they literally ruin the house,
Right.
then 5-ASAs are like installing a smart daily sprinkler system. You use them every single day, even when you feel perfectly fine, to keep the walls of the house damp so the fire has a much, much harder time ever starting again.
That is a perfect way to explain maintenance therapy to a patient. Because, as the clinical data points out, almost all of these medications, with the strict exception of steroids, are intended to be used to maintain remission long term.
You don't just stop taking them.
You don't stop taking the 5-ASA just because the bleeding stops.
Let's talk about that fire extinguisher then. The data says glucocorticoids, or systemic steroids, are added if the patient fails to achieve remission with 5-ASAs in 2 weeks. But it is incredibly explicit that steroids are not to be used for maintenance therapy. Why? If they work so well to stop the bleeding, why can't a patient just stay on a low dose forever?
Systemic steroids, like oral prednisone or intravenous methylprednisolone, are incredibly powerful blunt force instruments. They will rapidly shut down the entire immune system and put the fire out.
So they save the colon.
They save colons. But the side effects of continuous long-term use are biologically devastating.
What kind of side effects?
They cause severe, irreversible bone loss, leading to early osteoporosis. They induce rapid weight gain, steroid-induced diabetes, severe mood swings, and cataract.
That's a huge list.
And because they blunt the entire immune system, they leave the patient highly vulnerable to severe opportunistic infections.
So you can't stay on them.
You use the fire extinguisher to save the house today, but you absolutely cannot leave it running, or the toxic chemical foam will dissolve the foundation of the house.
So it's just a bridge.
The absolute goal is to use steroids as a bridge to transition the patient to a safer maintenance drug.
And if the 5-ASAs aren't strong enough to maintain that remission once the steroids are tapered off, what's the next step up the ladder? The literature mentions thiopurines, specifically azathioprine and 6-mercaptopurine.
These are classic older generation immunomodulators. They work by literally interfering with the DNA synthesis of rapidly dividing cells, specifically our friends, the white blood cells.
Okay, so they stop the army from growing.
Right. If the immune cells cannot replicate their DNA, the army cannot grow, the reinforcements never arrive, and the attack on the colon slowly grinds to a halt.
But there's a risk, right?
However, because they are actively suppressing the broader immune system and affecting cell division, they require rigorous, continuous monitoring of the patient's liver enzymes and total white blood cell counts to ensure you aren't suppressing the bone marrow too far.
But the real game changers mentioned in the research, the drugs that truly revolutionize this field, are the biologics.
Oh, without a doubt.
It lists anti-TNF-alpha drugs like infliximab, adalimumab, and golimumab. And it notes that infliximab is the most widely used, especially in severe hospitalized cases. What makes a biologic different from a normal pill?
Biologics represent a paradigm shift in modern medicine. These are not simple chemical compounds synthesized in a laboratory beaker like aspirin.
What are they then?
They are massive, complex, genetically engineered proteins, usually monoclonal antibodies themselves that must be grown in living cell lines.
Wow.
Remember earlier in the pathology section when we talked about TNF-alpha being the master cytokine switch for the inflammatory chaos?
Yeah, the switch that causes the swelling and calls the troops.
Drugs like infliximab are designed to act like highly advanced guided missiles. They circulate in the patient's bloodstream, actively hunt down those specific free-floating TNF-alpha molecules, and physically bind to them.
So they neutralize them.
Exactly, neutralizing them before they can dock with receptors and signal the immune system to attack.
That is incredible. You are deploying engineered antibodies to hunt down the body's own rogue signals.
It's beautiful science.
And there's another class of biologics mentioned here that is even more beautifully targeted. Anti-adhesion molecule inhibitors. Specifically, a drug called vedolizumab. The data says it works by blocking alpha-4 beta-7 integrin.
And this is where deeply understanding the pathophysiology we discussed an hour ago pays massive dividends.
Yes, this is a direct callback. I remember this. We talked about how the white blood cells use MAD-TAM1, the molecular Velcro, or the police spike strips laid out on the blood vessel walls to stick to the gut and dive into the tissue.
Exactly.
So how does vedolizumab tie into that?
Alpha-4 beta-7 integrin is the matching piece of Velcro located on the surface of the white blood cell itself. Vedolizumab is an engineered antibody that specifically coats the Velcro on the white blood cells.
Oh, I see.
So the heavy infantry cells circulate through the body, they reach the colon, they smell the inflammation, they see the MAD-PAM1 spike strips, but they physically cannot stick to them.
They just slide right past.
They just slip right past and harmlessly float away through the bloodstream.
So the army is mobilized, it's angry, but it is physically prevented from getting off the highway and entering the battlefield. That is wildly elegant.
It is highly elegant.
And I have to assume, because it only targets the gut-specific Velcro, it doesn't suppress the immune system in the rest of the body, like the lungs or the skin.
You've hit on the exact reason it is so revolutionary. It provides what we call gut-selective immunosuppression.
That's huge.
Unlike older drugs that suppress the whole body, leaving you vulnerable to pneumonia or skin infections, vedolizumab leaves the immune system perfectly intact everywhere except the digestive tract. It vastly reduces the risk of systemic infections.
The clinical review also touches on emerging and alternative therapies. It mentions probiotics and fecal microbiota transplantation, or FMT. It states FMT shows promise in helping establish healthy gut microbiota.
FMT is exactly what it sounds like, and while it carries a high ick factor for the general public, the science is profound.
How does it work?
It involves taking highly screened, healthy, diverse stool from a donor and transferring it directly into the colon of a patient with UC, usually via a colonoscopy or specialized enemas.
So replacing the bad bacteria with good bacteria.
The theory is to completely overwrite and reboot the patient's damaged pathological microbiome with a vibrant, healthy ecosystem.
Does it stop the immune attack?
If the disease is fundamentally driven by a breakdown in tolerance between the immune system and the local bacteria, physically replacing the bacterial population might convince the immune system to call off the attack.
That's fascinating.
It is still highly experimental and heavily regulated for UC, but the theoretical framework is incredibly compelling.
It also mentions a future molecular target, PPAR gamma. It notes that UC patients have reduced expression of this in their colonocytes, and that PPAR gamma acts as a negative regulator of NF-κB inflammation.
NF-κB is a major central protein complex that controls the transcription of DNA, cytokine production, and cell survival. It's the engine room of cellular inflammation.
Okay, so where does PPAR gamma come in?
PPAR gamma basically acts as the biological brakes on that NF-κB engine. In patients with UC, the brakes are physically worn out. That's the reduced expression.
So the engine runs out of control.
Right. Researchers are frantically trying to develop drugs to stimulate and repair what's left of the brakes. But as the literature notes, current drugs that target this pathway have significant cardiac and metabolic toxicity issues that currently limit their safety and use.
Before we move on from treatments, what about diet? I feel like that is the absolute first thing someone newly diagnosed would Google. What can I eat to cure my UC?
It's the most common question in the clinic.
But the clinical text is surprisingly, almost aggressively brief on this. It states there is no specific diet for UC, though lactose intolerance is common. And crucially, it says that unlike Crohn's disease, there is no role for elemental or parenteral nutrition.
This is one of the most frustrating and misunderstood aspects for patients. They desperately want a specific UC diet, a list of good foods and bad foods that will cure them.
Which makes sense, it's a gut disease.
But the harsh scientific reality is that while certain rough foods might trigger mechanical symptoms like dairy causing gas or highly fibrous, raw vegetables physically scraping against a raw ulcerated colon and causing pain food itself is not the underlying immunological cause of the disease.
You can't diet your way out of it.
You cannot cure an autoimmune genetic misfire just by eating organic kale and bone broth.
And parenteral nutrition means feeding someone intravenously, right?
Yeah.
Completely bypassing the digestive tract.
Yes. In Crohn's disease, sometimes completely resting the bowel by stopping all oral food and feeding a patient through an IV can actually induce disease remission.
But not in UC.
But in ulcerative colitis, clinical trials have proven that to be completely ineffective. The colon actually needs the short-chain fatty acids that are produced by the microbiome digesting dietary fiber in order for the mucosal cells to stay healthy and repair themselves.
Oh, so it needs the food.
Starving the colon of food does not heal it in UC. It actually deprives the cells of their primary energy source.
So we have the 5 ASA smart sprinklers, the systemic steroid fire extinguishers, the immunosuppressants, the biologic-guided missiles blocking the Velcro, and experimental microbiome reboots.
The huge arsenal.
But what happens if every single one of those fails? What if the fire simply cannot be put out, or the patient's body cannot tolerate the drugs? This brings us to the final reality of the disease, the last resort, surgical management and prognosis.
The stark, unavoidable reality is that for a significant percentage of UC patients, sometimes estimated up to 20 or 30% medical therapy will eventually fail, or the side effects of lifelong immunosuppression will become intolerable.
The clinical review states something very profound right at the top of this section. Colectomy is curative in patients with ulcerative colitis, since the disease is restricted to the colon. Colectomy meaning the major surgical removal of the entire large intestine. I have to ask you about this terminology. They call it curative. But is that really the right word to use with a patient?
Yeah.
If you have to remove the organ entirely, throw it in a biohazard bin, and completely reroute the body's internal plumbing, it feels less like a medical cure and more like a drastic final evacuation plan.
That is a very deep philosophical and very accurate medical debate among surgeons and gastroenterologists. Technically, pathologically, yes, if you physically remove the colon, the specific pathology of ulcerative colitis is gone forever.
Right.
The bloody diarrhea stops, the colon cancer risk drops to essentially zero. But you are absolutely right. You are exchanging one severe chronic disease for a surgically altered anatomical state that comes with its own lifelong permanent consequences. It is a massive, life-altering trade-off.
Let's look at the indications for surgery. Why would a doctor finally pull the trigger and send a patient to the OR? The literature lists failure in medical therapy, uncontrollable hemorrhage, strictures, high-grade dysplasia or cancer, growth retardation in children, and the absolute most frightening one, toxic megacolon.
Toxic megacolon is the absolute nightmare scenario in inflammatory bowel disease. It is a rapid, fulminant, immediate life-threatening complication.
The pathology mechanism described here says it involves the muscularis propria, leading to nerve damage, which leads to dilation, peristalsis, and ischemia, and that it is the most common cause of death in UC patients. Walk me through exactly what is happening inside the patient's body when this hits.
Remember, at the very beginning, we established that UC is usually superficial. It respects the boundaries and stays in the mucosa and submucosa.
Right, doesn't hit the muscle.
But in a fulminant, incredibly severe attack, the sheer unbridled volume of inflammation breaches those inner layers and begins to literally digest the muscularis propria, the thick, heavy muscle layer of the colon wall.
The structural support beams of the house.
Yes. And embedded deeply within that muscle layer is a complex network of autonomic nerves that control peristalsis, the smooth, wave-like muscular contractions that move gas and stool along. The intense inflammation literally paralyzes these nerves. The muscle tone is completely lost. A peristalsis means all muscular movement stops entirely.
So the colon just gives up. It stops working.
It gives up completely. And because bodily gases and fluids are still continuously pouring into it from the small intestine, the paralyzed, flaccid colon begins to expand and balloon outward rapidly.
That's the megacolon part.
Right. As it stretches further and further, the blood vessels supplying the colon wall get stretched tight and pinched off. That causes ischemia, a critical lack of oxygen to the tissue.
So the tissue starts dying.
The colonic tissue begins to die, become necrotic, and eventually the highly pressurized, paper-thin, dead wall of the colon tears open, rupturing and spilling trillions of highly toxic gut bacteria directly into the sterile abdominal cavity.
Which instantly leads to massive sepsis and septic shock.
Exactly. The mortality rate, if it ruptures, is catastrophic. Yeah. It requires emergency, life-saving surgical intervention to remove the colon before it bursts.
But let's say the surgery is planned, not a life or death emergency. A patient just can't take the flares anymore and opts for surgery. What are the actual procedures?
There are two main options.
The text lists proctocolectomy with ileal, pouch, anal, and anastomosis, which is a massive mouthful, but it's commonly known as an IPAA or a J-pouch. And the alternative is a proctocolectomy with an end ileostomy. Let's translate what the surgeon is actually doing.
Let's break those down. A proctocolectomy means the surgeon is removing the entire colon and the entire rectum.
Okay.
Once those organs are gone, you have the end of the small intestine, the ileum, just dangling there in the abdomen. You have to do something with it to allow waste to exit the body.
Right, the plumbing has been cut.
So option 1 is the ileostomy. The surgeon brings the end of that small intestine through a surgically created hole in the abdominal wall and stitches it directly to the skin.
And that's the stoma.
This exposed piece of intestine is called a stoma. The bodily waste now empties directly from the small intestine out of the abdomen into a specialized external appliance bag that the patient wears under their clothes 24/7.
And the J-pouch. Because I know a lot of younger patients opt for that to avoid the bag.
The J-pouch, or IPAA, was a surgical marvel developed to help patients maintain a more normal body image and avoid wearing an external bag.
How do they do it?
The surgeon takes the very end of the small intestine and folds it back on itself, stitching it together and shaping it into a J or a W to create an internal reservoir or a pouch.
Okay, a fake rectum.
This pouch acts exactly like a faux rectum. They then pull this newly created pouch down into the pelvis and connect it directly to the patient's original anal sphincter.
So the patient can still evacuate waste relatively normally sitting on a toilet without an external bag.
Exactly. It restores a semblance of natural anatomy and continence, but it is absolutely not a perfect system.
What's the downside?
You have to remember, the tissue of the small intestine was evolutionarily designed to absorb nutrients quickly, not to store caustic, highly acidic liquid waste for hours. By forcing small bowel tissue to act like a rectum, the tissue is subjected to severe mechanical, chemical, and bacterial stresses it was simply never built for.
Which brings us to the brutal list of surgical complications. Leak from anastomosis, pelvic abscess, pouch prolapse, pouchitis, incontinence, sexual dysfunction. Pouchitis specifically is defined here as acute or chronic inflammation of that newly created J-pouch.
Right. Because you've radically altered the anatomy, the flow of waste, and the bacterial environment, the microbiome within the newly created pouch can become severely imbalanced.
And what does that feel like?
This leads to inflammation of the pouch that closely, sometimes identically, mimics the symptoms of the original ulcerative colitis: urgency, bleeding, pain. And repairing or medically dealing with a failing J-pouch is incredibly complex.
And the sexual dysfunction.
Furthermore, because these surgeries involve deep, extensive dissection in the narrow space of the pelvis, there is a very real risk of the surgeon inadvertently damaging the delicate web of nerves that controls sexual function and urinary continence.
This entire section really highlights why the clinical review is so adamant about the enhancing healthcare team outcomes section. Managing this disease, especially post-surgery, isn't just a matter of seeing a doctor once a year.
Not at all. It requires a vast, tightly coordinated interprofessional team.
The review mentions clinical pharmacists to ensure medication compliance and monitor for toxic drug interactions. Nurses to aggressively encourage hand washing and vaccinations because these patients are intentionally immune suppressed.
Dietitians are key too.
Right, specialized dietitians to help them navigate the very real mechanical challenges of eating with a stoma or a high-output J-pouch. Wound care and stoma nurses who are absolutely vital to teach patients how to physically manage, size, and change their appliances without getting severe skin breakdown. Social workers for the crushing financial burden of biologics. And mental health counselors.
Yes.
The text specifically and importantly notes that many patients with UC develop severe depression and anxiety. When your entire life is tethered to the proximity of a bathroom, when your body image is fundamentally altered by surgical scars or an ostomy bag, and when you are dealing with the invisible exhaustion of chronic pain and anemia, the psychological burden is immense.
It requires dedicated psychiatric support.
Absolutely.
And on top of all of that daily management, there is the long-term, lifelong monitoring. The pearls and other issues section is very sobering about this. There is an increased risk of colorectal cancer in patients with ulcerative colitis. The risk is cumulative, with a 2% chance after 10 years, 8% after 20 years, and 20 to 30% after 30 years. A 30% chance of developing colon cancer simply because you've had this disease for 3 decades.
The biology behind that is a numbers game.
How so?
Chronic, relentless inflammation physically drives cellular turnover. The faster mucosal cells are killed, the faster the body is forced to divide and replicate cells to repair the damaged tissue. And that leads to errors.
Yes. The faster cells divide, the higher the mathematical probability that a random genetic copying error will occur, leading to dysplasia, which are precancerous cellular changes, and eventually outright malignant cancer.
Which means lots of scopes.
This is why the medical guidelines universally mandate intense surveillance colonoscopies with dozens of random biopsies every 1 to 2 years for any patient with long-standing disease.
And because of the powerful biologic medications they take to suppress the immune system, the text also mandates regular screening for melanoma and non-melanoma skin cancer, and aggressive vaccinations for pneumococcus and the flu, and regular DEXA bone density checks because of the past steroid use destroying their calcium levels.
It is a lot to manage.
It sounds like it is a full-time, exhausting job just being a patient.
It is a second job. But the clinical review does offer one vital piece of statistical reassurance. Overall mortality is not greater than in the general population, assuming complications like toxic megacolon or late-stage cancer are avoided through this intense monitoring.
But they can live a full life.
The ultimate goal of all this medical management, the drugs, the surgeries, and the scopes, is to give the patient a completely normal lifespan, even if the daily quality of that life requires constant, vigilant maintenance.
This has been an unbelievable, intense journey through this material. We started with a hyperactive, broken radar system in the gut, moved through the bizarre environmental paradoxes of smoking and appendectomies, witnessed the microscopic friendly fire of neutrophils and TNF-alpha.
We covered a lot of ground.
We explored the systemic havoc the disease wreaks on eyes, skin, and joints, evaluated the cutting-edge biologic-guided missiles designed to stop the war, and finally looked at the stark, life-altering reality of surgical evacuation.
It truly demonstrates the incredible, overwhelming complexity of the human immune system and the gastrointestinal tract. It shows how much we know, and terrifyingly, how much we still have to learn.
But before we wrap up, I want to leave you, the listener, with a final concept to mull over based on the deep implications of everything we just unpacked. We learned earlier about the appendix mystery, that physically removing the appendix before age 20 reduces UC risk by nearly 70%. We also learned that fecal microbiota transplants, literally introducing foreign bacteria to overwrite the colon's ecosystem, can help push the active disease into remission.
Yes. Two highly distinct physical interventions that fundamentally alter the gut's microscopic environment and immune training.
So here is the provocative thought. If physically altering our gut microbiome, either by taking out a tiny, supposedly useless pouch like the appendix, or by introducing foreign bacteria can drastically, permanently rewrite the fate of our immune system, what does this mean for the entire future of autoimmune diseases?
It's a profound paradigm-shifting question.
Could the colon, the microbiome, and the appendix actually be the ultimate master training grounds for the entire body's immune system? Think about the implications of that. If we learn to perfectly map and hack the gut microbiome in early childhood, could we move past the era of just managing diseases like ulcerative colitis with heavy, dangerous immunosuppressants? Could we actually stop the body from ever learning how to attack itself in the first place?
It suggests that the future of medicine might not be about building better, more expensive fire extinguishers, but about preventing the microscopic sparks from ever igniting.
Exactly. Going back to our opening, maybe the diagnostic X-ray machine for these autoimmune diseases won't be looking at the damaged bleeding tissue itself. Maybe the diagnostic tool of the future will be a perfect predictive map of our microbiome, allowing doctors to spot the cellular rebellion and shut down the boot camp before the first shot is ever fired. Thank you for joining us on this deep dive.